and welcome to another episode of the JASN podcast, where we take a deep dive into exciting new research from JASN. I'm Kurella Tamura from Stanford University School of Medicine and Deputy Editor of Clinical Science at JASN.
And I'm Ben Lazarus, nephrologist at the Queensland Kidney and Transplant Service in Brisbane, Australia, and the Junior Associate Editor at JASN. Today, we're exploring a controversial topic in nephrology and transplantation: when and why to perform coronary angiography in patients being evaluated for kidney transplantation.
That's right, Ben. We're joined today by Dr. Avantika Israni, first author of a new paper in JASN entitled Class 1 Indications for Coronary Revascularization Identified in Pre-Kidney Transplant Screening. Welcome, Dr. Israni. Could you introduce yourself and tell us a bit about your background?
Thank you for having me. I'm really excited to be here. I love podcasts. So this is my first podcast ever, which is very, very cool. My name is Avantika Israni. I'm a transplant nephrologist at the University of Arkansas for Medical Sciences. I just finished my training, general nephrology and transplant nephrology at NYU Langone. And this is my first attending job. And I worked on this paper as a fellow. Clinically, I look after kidney transplant recipients and candidates, and academically, my work is currently focused on the cardiorenal interface in transplantation, as well as delayed graft function. This project grew out of day-to-day discomfort that I felt as a fellow, that we were putting every candidate through, some kind of coronary screening. And it wasn't really clear how often we were actually finding disease where guidelines clearly say that this person should be revascularized. That's the gap we try to quantify in this paper.
So, we know that many kidney transplant assessment programs routinely make their patients go through these screening tests for coronary artery disease, as you say, but that the opinions on the utility of this testing differ. So, for example, the 2020 KDIGO guidelines recommend that candidates at high risk coronary artery disease or with poor functional capacity should undergo non-invasive screening for coronary artery disease, whereas the latest 2022-2023 AHA-AST statement recommends against invasive coronary screening in asymptomatic kidney transplant patients. Can you, Dr. Israni, elaborate on what's happening in clinical practice and the motivation for your research question?
Yes, so what's happening in clinical practice? I think that's the big question. Practices are very different and very center specific. When I was at NYU, we would basically do coronary angiogram for every diabetic patient, no questions asked. It's slightly different at University of Arkansas, where we kind of go through the stress testing and, we get coronary calcium score and then decide if we want to pursue, cardiac cath. Also, practices differ based on dialysis vintage sometimes. If you've been on dialysis more than 5 years, NYU would like you to get an angiogram. That's not really the case here. So I guess that's why the motivation came from this desire to have an answer to, this question that who do we really need to screen and what is the real, what are we actually finding? So that's why we needed to do like a systematic review and meta-analysis, because there's no single center that has enough patients to answer that question precisely. And the literature is very fragmented, with different centers, different eras, different testing strategies. I wanted to apply a consistent definition of class 1 indication across all studies and quantify the prevalence of like the must revascularize lesions, obviously along with, seeing what's the burden of multi-vessel disease. And I also wanted to see how many of these patients actually end up in the cath lab. So I guess these were the reasons as to why and the motivation behind this study.
Thanks so much. Maybe before we dive into your study results, we can take a minute to talk about the ischemia CKD trial for our listeners who aren't as familiar with the literature, because I think that trial is important context in some ways. So the ischemia CKD trial compared invasive and conservative revascularization strategies in patients with stable CKD, moderate to severe ischemia without left main disease, and advanced CKD. And I believe the trial did not show a benefit to the invasive strategy in the overall population. There was also a post hoc analysis of the transplant waitlisted patients, which also showed no benefit. Is that right? Can you tell
Correct.
us a little bit more about that result and sort of how does the field interpret ischemia CKD in relation to the recommendations from KDIGO or AHA?
So yeah, the ischemia CKD already told us that even among patients with at least moderate ischemia on stress testing, invasive strategy didn't really improve outcomes compared with the conservative one, including the 194 patients, who were actually waitlisted for transplant, and the adjusted hazard ratio for invasive versus conservative strategy was 0.91 with a wide confidence interval. At the same time, we have the new trial, the CARSC trial, that is asking a complementary question, whether we even need to keep screening asymptomatic illicit patients. I think my study was, our paper zooms into a much more basic, almost pre-trial question as to, when we do coronary screening, how often do we actually find coronary anatomy that meets the AHA ACC class 1 indication? I think that was like the question that we had. I have brought up the ischemia CKD trials so many times in so many committee meetings in the last, 1.5 years, but I don't think the surgeons or even the transplant nephrologists feel comfortable when I cite that data that, there was no evidence of, an invasive strategy. So I'm trying. This is me making another effort.
Yeah, it's always one of those things if you have a post hoc analysis of the ischemia trial, I guess, and you have your individual patients. I think, as you mentioned, there's like the CAST trial that's happening to try and further look into that and further research. But do you want to, can you tell us a bit more about the key findings from your paper and what are the main findings you found there?
Sure, absolutely. So we screened around like 1,273 studies, ultimately included like 44 cohorts. And basically, our main findings was the mean prevalence of AHA class 1 indication for coronary revascularization, which was around 2%. There was substantial variation across studies, with estimates ranging from 0 to 17%. But when you pool everything, it's still very low. Left main disease was around 1%, proximal LV disease was 2%, and multivessel CAD of any sort was 10%. Despite that, about 35% of patients were referred for invasive coronary angiograph as a part of their, pre-transplant assessment. In meta-regression, we didn't really find any strong evidence that prevalence of class 1 indication, varied systematically by diabetes prevalence, hypertension prevalence, or sex distribution. So basically, even though we're doing a lot of screening and a lot of angiographies, we very rarely find coronary disease where guidelines clearly say that this patient should be revascularized. And that really calls into question, the yield of routine blanket screening.
Thanks so much. You touched on some of the factors that perhaps led to some heterogeneity or differences. I wonder if there are other factors that you think might contribute to heterogeneity but weren't captured in the data set, like center level variations or, year maybe. Like what are the things that maybe should be captured in future studies?
Yeah, absolutely. When I look back at the manuscript and I look at the forest plot, that's not very pretty. There's a lot of heterogeneity. I think there are a few reasons. I think every center had like a different screening strategy and different screening threshold. Some centers did very liberal screening where essentially everyone gets a stress test and everyone gets, coronary angiogram. Others used more like selective algorithms, or they applied pre-screening with echo stress tests. So only the highest risk patients ever made it to angiography. So it was very different. There were differences in underlying population. Like some had like really, old patients, some had like a high, diabetes burden. The dialysis vintage differed in all of these, cohorts. And also the proportion of patients with known CAD at baseline varied quite a bit between the cohorts. So, like a program with older, more diabetic patients that sends only like highly selected patients to CAT will, obviously, report a higher prevalence of severe disease. Also, the cohort size, I would say, like there were some smaller cohorts. So even if you have like a fewer people with class 1 lesions in a small denominator that can quickly like translate into a high percentage. So we did try to see if we could explain some of the heterogeneity with some obvious candidates like sex distribution, hypertension, diabetes, but those didn't account for in the meta regression.
Thanks. Yeah, I think the forest plot looks great. I don't know what you're talking about. It looks good. So you looked at two class one AHA indications for coronary revascularization, namely multivessel coronary artery disease that's suitable for CABG with a left ventricular ejection fraction of less than 35% as one indication, and then significant left main stenosis as a second indication. What about the patients with 2A and 2B recommendations? Could they still benefit from coronary revascularization?
Yeah, that's a really important nuance that I think it's important to discuss. I think we deliberately focused the primary endpoint to be class 1 indications because that's where the guidelines say patients must be or should be revascularized. In general, like we already discussed, the ischemia trial didn't really show a benefit of revascularization or optimal medical therapy if someone has stable CAD with preserved EF. But I think class 2A, class 2B lesions should absolutely be considered in an individualized setting, especially if someone has like severe symptoms like angina or someone has like very proximal LAD disease with like a large ischemic territory. But I think that has to be done like on an individualized cardiology, nephrology discussion. But this doesn't rescue the logic of broad, routine blanket screening of asymptomatic candidates. And that's like the only thing that I would like to emphasize. So yes, do
Yeah.
certain patients who have class 2A, class 2B lesions be considered for revascularization 100% if they have symptoms or if you are thinking of decreasing like perioperative risk. But I don't think this should lead to like routine blanket screening of
Yeah.
asymptomatic candidates.
Mm. I guess many nephrologists in Australia will get a resting transthoracic echocardiogram before referring their patients to a transplant assessment service. And so those patients who have an ejection fraction of less than 35% wouldn't be referred for waitlisting, but could still have benefited from that resting echocardiogram in the first place. So I guess from like a clinical perspective, I'd be interested in, if we already know that my patient has a resting echo and they don't have a low ejection fraction, what's the probability that they have an indication for coronary revascularization once we already know that they have a normal resting echo? Do you have any data or comments on that?
Yeah, that's a helpful distinction. I think in the US, we generally don't use echo that way. Patients are referred first, and then the echo is done later as a part of the transplant evaluation. I think a big reason for that is because generally the transplant centers would pay for it. So I guess we do the echo much later. There have been times when I've actually discovered that, we did this echo and the patient's EF is 30%, and then we exclude them from the wait list. But in terms of our data, our review couldn't estimate the probability of revascularization indications conditional on a normal echo because EF stratified reporting wasn't consistent. I mean, there were a lot of studies that didn't even report the EF. And what I can say is that even without conditioning on echo findings, clear guideline-based indications, especially class 1, were uncommon. So if you restrict to patients with a normal resting echo, I think the likelihood is just as low, if not lower.
Well, this has been a super fascinating conversation, and I think you've definitely empowered some nephrologists out there, including me, to push back on the transplant center a little bit when our patient gets referred for an angiogram. Maybe to wrap up, what do you think, what are the open questions, the big open questions in this field, and where do you see this line of research going in the future?
So with this study, I guess, I've always wanted to make kidney transplant less burdensome and more like thoughtful and access to be much easier. This was like the first study that I did that helped me achieve that. I hope it did. I hope it does. I don't know. I did send the paper out to my, colleagues. I'm not sure if we're going to change any practice. But I guess I managed to show that there is little benefit, I guess. Maybe I'm overstating my findings. I don't know. But the next step I want to show is that there's actually harm. We're actually delaying these patients. The deferral rates are high, right? The waitlist mortality is high. think that would be like the next study that I would like to see, whether I can do it or anybody else can do it, is to actually take a look at how long it's taking. Because getting a cardiac cath takes 6 months, sometimes 7 months. And even for lesions that don't necessarily require revascularization, sometimes we go ahead and stent it, and then they require DAPT for another 6 months, which again delays their listing. So I guess that the fact is we've shown that there's little benefit. I think the next step is to see the harm. And I think that's the only way to really change this practice. I guess that's the future work that I'm looking forward to, is just identifying where our current practices don't match the evidence and building better pathways to serve our patients.
Well, thank you so much for this really, stimulating conversation. On behalf of Ben and myself, I think we've really, really enjoyed it, and we're looking forward to see what your research shows next.
Yes, I'm really looking forward to it. I'm really excited. Thank you for having me. This is awesome.
Thanks so much, Israni.
Okay, thank you.
And thanks for submitting to JASN.
Of course, thank you.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition, or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.